My name is Haley Alcorn, and this is my Analysis of a Quality Initiative presentation. This presentation is over the Plan, Do, Study, Act model to improve hand hygiene compliance in the primary care setting. While shadowing a nurse practitioner in the primary care clinic, I observed the clinic for safety practices. I noticed that in this clinic that hand hygiene practices were poor. The staff only wash their hands about 60% of the time before and after patient encounters. The staff all had a laid-back attitude towards hand hygiene, and hand hygiene was never addressed, which probably contributed to this. There weren't any posters, there was nothing said about hand hygiene all day, and leadership said nothing about hand hygiene. The providers, nurses, and ancillary staff all had patient care, and they should be using hand hygiene more consistently to comply with standard safety practices. The Plan, Do, Study, Act model is a 4-step tool used for quality improvement that can be easily applied to healthcare. This tool is simple and straightforward. The first step of the PDSA model is the plan phase, where an intervention is planned to be tested, and also data collection methods should be included in the plan too. The next stage is the do stage, where we'll perform the test of the intervention on a small scale, collect data while we're doing that, and also observe for problems. In the study phase, we'll analyze the data collected in the do phase. We can look for improvements with this and use graphs as a visual aid to summarize our findings. In the act phase, we will implement changes that were successful and refine the change to plan for the next test cycle. Before we can begin to use the PDSA model, it is important to have a clear objective. My objective for this quality improvement project would be to improve hand hygiene compliance within the clinic to 95% over the next 3 months. This goal is clear, measurable, and time-specific. There are a number of interventions that could be used, but for this slide I just used an example of holding a brief hand hygiene in service that stresses importance of hand hygiene and proper hand hygiene technique. During the plan phase, it's important that we address the who, what, when, where, and how of the test. As far as who is concerned, all clinical staff that has a patient interaction should be involved with this change. And who will collect the data should be the office manager. The what is the use of hand sanitizer or soap and water before and after each patient encounter, and that is what we will be measuring. When this should be over the next 3 months, as stated in the objective, and probably on random days chosen by the office manager. Where is in the primary care clinic. How we plan to do this is direct observation or observation through security cameras. During the plan phase, you can also make predictions about what is going to go well and what could be problems in the process. For instance, a problem with this process could be that with direct observation by the office manager, this could lead to the Hawthorne effect, or people behaving differently when they know someone's watching them. During the do phase of the PDSA model, we'll begin to actually run our test. The instance used for this first cycle was holding the hand hygiene in service. During this in-service, they should cover why hand hygiene is a priority, explain the goal to the staff, and explain that they are not as compliant as they should be. There should be an example of proper hand hygiene techniques, and an opportunity for staff to represent that they know and learn proper hand hygiene. After the in-service, we could begin to collect data. This would be done by the office manager directly observing staff to see if they are compliant with hand hygiene practice and document this. During this time, the office manager should also be observing for problems with the process. In the study phase, we'll take all of the data collected by the office manager and we'll analyze it to see if there was any improvement in hand hygiene compliance after the in-service. We can put this data into a run chart and label the intervention that was done on this PDSA cycle. In a run chart, it'll give you opportunities to label each change with each PDSA cycle to show which interventions led to the most improvement. During the ACT phase, we will continue changes that were improvements and make adjustments where necessary to prepare for the next test cycle. For this project, if improvement was noted after the hand hygiene in-service, then we wouldn't necessarily need another in-service, but we could go ahead and plan to implement some information into a daily huddle as our next change cycle. Phelps and Reed performed a study in the hospital that used the PDSA tool to improve hand hygiene compliance rates to over 95%. During their test, they looked at why people were non-compliant to come up with ideas for interventions to test out in the PDSA cycles. Reasons for non-compliance that they found were forgetfulness, hands drying out, poor placement of hand sanitizer dispenser, or a long time between refills of an empty dispenser, and that people would rather use scented sanitizer sometimes, which is also something that I noticed in the clinic. There were several occasions where the staff member would leave the room, touch a bunch of stuff after leaving the room, but when they got back to their station, they would use their personal scented sanitizer. Interventions they used to address these: for forgetfulness, they put a stop sign outside each patient door, reminding staff to wash their hands. Another thing we could do to address forgetfulness would be to incorporate some information over hand hygiene into the daily huddle to show that hand hygiene is a priority. To address hands drying out, Phelps and Reed started placing lotion dispensers at the nurse's station and various places throughout the hospital, and I think this could be applied to our test as well. They rearranged hand sanitizers to be most efficiently located. One thing I noticed in this clinic was that there weren't any hand sanitizers outside the x-ray room, so that would be something that was important. And they also streamlined the process of refilling empty sanitizer dispensers. They did not do anything to address the fact that people would rather use scented sanitizer, but that's another intervention that could be looked into. Cotter's 8 stages of change are a tool that can be used to help us implement our quality improvement into the primary care clinic. This picture is taken from Team Steps Module 9, and the stages of change are from bottom up. And the first stage of change is creating a sense of urgency. In the clinic, we could create a sense of urgency by first letting the staff know that hand hygiene is a priority and also letting them know where they're at on their compliance, which would be around 60%. Another way to create a sense of urgency in this clinic could be to remind them that flu season is approaching and how important hand hygiene can be in preventing infection. The next step is to build the guiding team. I think for this guiding team, it would be beneficial to have a team member from each part of the department. So 1 provider, 1 nurse, 1 ancillary staff member, and the office manager to kind of drive the change. Developing a change vision and strategy. The office manager and leadership should define a culture of safety and make it known to the staff that they value hand hygiene at this clinic. This is where you want to make it known that hand hygiene is a priority in the clinic and that they should take pride in complying with that. In the understanding and buy-in, it's important to accept and plan for resistance. This could be done by having an open conversation with resistors. such as the office manager approaching them in a private manner and pointing out, "Hey, I noticed your hand hygiene compliance is particularly low this last week," and talking to them about why, which could lead to them giving information about opportunities for improvement. In empowering others, you can set short-term goals. You could train the staff well. By the in-service would be an example of that, and how exactly to perform hand hygiene to be compliant with the clinic's standard. Producing short-term wins helps to motivate the team and builds momentum. This could be done by saying, "Hey, we've improved our hand hygiene rates by this much. Let's keep building on that and keep working towards our goal. Great job, guys." In the don't let up stage, this is where we could keep performing cycles and continuing to try and improve with different interventions. This is not stopping until we reach our goal, and even after we've reached our goal, keep reminding staff how important it is. The final stage of change is the hardest to do, in my opinion: create a new culture. There's a reason this is the last stage, and that's because everything else is kind of building up to this. At the end of the day, people like to work somewhere they can be proud of. And by creating a culture that prioritizes hygiene, hand hygiene, and safety practices in general, that's something that all the staff members can be proud of. The PDSA model has proven to be very effective in primary care. In the study done by Wyatt, Shropshire, Estrada, and Patrician, they improved the control of hypertension in VA patients by using the PDSA cycle. In their study, instead of doing one intervention with each cycle, they did bundles of interventions and just did 2 cycles. During the plan phase, they planned which interventions they were going to use by looking at the strengths and weaknesses of their current system. They also determined how they were going to collect data and what they were going to define as blood pressure control. In this case, they used a systolic blood pressure of less than 140 but greater than 90. In the do phase, they implemented their bundles. For instance, the first bundle of interventions they used included meaningful use of the EMR, a medication adherence assessment performed at each visit, providing home blood pressure monitors and logs, and implementing telemedicine phone visits. In the study phase, they studied data over a period of 3 months and also over 6 months. They found that they increased their blood pressure control rates from 62.3% to 71.8%. And while this might not seem like a very dramatic increase, it's important to note that there were 900 veterans involved in the study, so there were several lives affected by this improved control. In the ACT phase, they continued to implement the changes that they had made and planned for more follow-up studies. In another study that was done in Australia, in a community that had high cervical cancer rates and low screening rates, a clinic improved their pap smear rates in an urban community care center. They did this with PDSA cycles, and they used 5 cycles. In the planned phase, they planned which interventions they would use based on literature shown to improve pap smear rates. In the do phase, they implemented changes. They started with a data collection tool and implementing promotional material into the office. They also used other interventions later on in different cycles, such as education on prevention of cervical cancer and how important screening can be. In the study phase, they analyzed data and saw improvement in their rates. In the ACT phase, they continued to perform rapid PDSA cycles, and they followed up at 5 and 10 months and saw a drastic improvement in their rates. What makes the PDSA cycle so great in primary care is that it's straightforward and easy to apply for improvement processes. That concludes my presentation, and these are my references.